Welcome to the Valley Wellness Podcast. I am Dr. Tennille Cloward, and I am here today with Taelor Lewis. And we are going to be talking about something very exciting, the subject that is frequently termed GSM.
Yep.
What is GSM?
GSM stands for Genitourinary Symptoms of Menopause. That's a mouthful, but it used to be called vaginal atrophy.
I don't like that word.
Right? Yeah. Well, before that, it used to be called the senile vagina.
Oh my gosh.
So that's
It
so
only gets
rude.
better.
So rude. Like we should never talk to our vaginas like that.
No.
But I mean, vaginal atrophy does explain a little bit of what is really happening because that's what's happening. The vagina is atrophying, but I like GSM better. It was renamed in 2016 to add that urinary component to GSM. I think it better describes what's going on overall with GSM.
Significantly easier to say, too.
Yeah, for sure.
Genitourinary symptoms of menopause.
Correct.
Yep. What causes it?
Well, first of all, the definition, and I'm going to read this from the American Urology Association. The definition of GSM is a spectrum of symptoms and physical changes resulting from the decline in estrogen and androgen concentration in the genitourinary tract during the menopausal transition. So the American Urology Society recently came out with new GSM guidelines that includes vaginal estrogen. So that was in 2025. So recent as in just barely. And then about a month ago, the FDA finally removed that black box warning saying that vaginal estrogen could potentially cause breast cancer in women. So that was a huge movement for women's health.
Amazing.
So between those two, I think it's just time to have a conversation on what GSM is and how to treat it adequately.
Bust it out of the closet. Let's quit pretending that it is not something that is
a huge problem for women.
A big problem.
Yeah.
Yes. Okay.
Yeah.
Well, now let's
talk about what it is.
Yes.
Yeah. So GSM is the natural decline of hormones. Hormones that created these tissues and these organs to be adult, mature tissues and act in the way that they need to for our sexual and reproductive health. So when we went through puberty, they it helped develop our clitoris, our labia, our vagina. We started having discharge and having lubrication and helped prepare those structures for adulthood. And when those hormones go away, when we outlive our ovaries, and that's a term that I stole and I use all the time from a very renowned urologist by the name of Dr. Kelly Casperson, who's huge in this women's health space also. And so we've outlived our ovaries. We've outlived these hormones, and changes start happening in the urogenital area. And we start to see thinning and atrophy. We lose blood flow. We lose the vagina literally shrinks. The bladder weakens. We have urgency and frequency and so many other symptoms, but also major, sometimes life-threatening problems that can occur. So,
right. So is this just aging or is this a disease?
Yeah. So it's both, right? It's both. I mean, we've aged. Again, we've outlived our ovaries. And then this is a medical condition. The vagina isn't just for sexual intercourse. I mean, most women want to have a healthy sex life while they want it. So there are a lot of problems that can occur with sexual function of these structures with the decline of hormones. I mean, I've had so many women, and I'm sure you have as well, describe sex to me as razor blades.
Right.
Razor blades.
It just burns.
It burns, it bleeds, it tears. Sex is painful, so that leads to low libido and so many other things.
It can be really disruptive in their relationships.
Yeah. And then there's the urological side of things. So we're talking about urethral thinning, weakened bladder support, increased urinary urgency and frequency, frequent UTIs, which for some of these women, for frail, older women with comorbidities, urosepsis can be life-threatening for these patients. There's a myriad of symptoms, and we often don't recognize, realize, understand the reason behind it. Sometimes we just think, this is just aging.
Getting older.
This is just getting older.
And this is just part of it.
Right.
What's actually happening, though, to those tissues as the estrogen is declining?
Well, first of all, we have estrogen receptors all over our body. We tend to think that estrogen is just for our ovaries, it's just for our sex and reproductive hormones or our structures, but we have estrogen receptors in our brain, in our bones, in our breast. Everywhere, and in our vagina. And as estrogen declines, we start to literally lose tissue. I mean, that's why it was called vaginal atrophy, because those vaginal tissues really do disintegrate. They go away. And then we lose the health and protection of our urethra and our bladder. So let's talk about symptoms. So and break it down by system. So if we're looking at vulvovaginal symptoms, so that's just the vaginal dryness, the irritation, the dryness, soreness, redness, itchiness, etc. Then there's the urinary symptoms, and that is dysuria, so painful urination, frequent urination, bladder spasms, frequent UTIs. Then there's the sexual portion of painful intercourse, or just pain in general. I mean, I've had women say it hurts to wipe, my underwear is aggravating, it hurts to wear jeans. And then there's also difficulty with arousal. So we really do lose blood flow to that area. And with loss of blood flow, it's more difficult to become aroused. It's more difficult to achieve orgasm. The clitoris shrinks. Everything just changes. Yeah. So much to the structures, and the sensation occurs with that loss of estrogen and androgen as well. Testosterone is a part of that also.
I love how much we've learned about this topic. I think back to my training when I was in residency, and I would have a patient who came in, was complaining of urinary incontinence, and not just the stress incontinence, but even the urge incontinence. And immediately we're talking about lifestyle things, bladder irritants, and then medication.
Mm-hmm.
And it was never estrogen.
Yeah.
It was medications that are going to cause nasty side effects like dry eyes and dry mouth, and that are not very tolerable for a lot of women.
Especially the older population.
Estrogen.
Yeah. Yeah. We know now nothing decreases UTIs better than a well-estrogenated vagina.
Estrogenized vagina.
Yes. Thank you.
Yes. We'll try and between the two of us split it up.
Yes.
Get the right word.
Well-estrogenated vagina. Absolutely. We know that now. It works better.
Right.
It works better at preventing UTIs. It works better than anticholinergics, which are those medications that you mentioned. And studies have shown, and now in the GSM guideline, estrogen is the first line treatment. If it was up to me, vaginal estrogen would be over the counter. And it is in Europe. We just are having a lot slower time catching up.
I hope we get there.
Yeah.
Hopefully, eventually, it started with the removal of that black box warning, and that was a major step in the right direction there.
Yeah.
How common is this?
Oh, super common. Yeah. Super, super common. So 100% of women have vaginas, and 87% of those women have GSM. So that's huge. But unfortunately, only about 50% say that they are talking to their providers about these symptoms. And I often think I love again that we're adding the urinary component to this, because I don't care if you're sexually active or not. A lot of women will say when I start to talk about these things, oh well, I'm not having sex anymore. Like my husband's died. I'm not sexually active. I don't care. This is still a structure that you need to be aware of and take care of for your long-term health.
Right.
Yeah.
Right. I don't remember how many times my grandmother would call me and say, Tennille, I have another bladder infection. Will you prescribe? I was prescribing her antibiotics left and right when I could have just been prescribing her a vaginal estrogen cream.
Right. My mother 10 years ago spent 8 days in the ICU for urosepsis and has struggled with recurrent UTIs ever since. And I've got her on vaginal estrogen, and it's made a huge difference. Life-changing
for her.
Yeah, absolutely.
I feel like, that this is very common, as you mentioned. I feel like there's a little bit of a spectrum, though. Some women women might have very mild symptoms. Some women are going to have very severe symptoms that significantly alter their daily lives because of how uncomfortable they are.
Just circling back to the UTIs really quick. There's two different causes, big main causes with recurrent UTIs. And a lot of women think, it's got to just be a cleanliness issue, right? Like I'm just not cleaning enough. I'm not bathing enough. Like what is happening? And this is kind of where I geek out a little bit because it's super interesting what's actually happening to the microflora of the vagina with the loss of estrogen. So yes, we're losing the structures that support the urethra and protect the urethra. So we may find women that, every time I have intercourse or I'm sexually active, I have a UTI. There's that group because, again, we're just losing those tissues that protect the urethra. On the other side is that estrogen helps promote the good bacteria in the vagina, which is that lactobacillus.
Right.
And so without estrogen, we lose that lactobacillus. When we don't have the good bacteria, the bad bacteria flourishes. Right. So
the environment changes
absolutely
down there.
Yeah. So I will often compare this to like a yard of grass, right? So if we fertilize the grass and the grass grows really, really strong, then the weeds can't grow. Well, as soon as we don't have estrogen to fertilize that lactobacillus, the lactobacillus goes, weeds proliferate, and then we do just have recurrent UTI. As soon as I'm done with an antibiotic, boom, that bad bacteria flourishes again, and and then we have a myriad of other problems like gut disruption and C. diff and so forth. So anyway, that's just kind of the nerd in me, the science in me.
I like the nerd in you, Taylor.
Behind what is really happening.
So how is something like this diagnosed? Is there a specific test that's done, or is this just clinically? Yeah, so not a specific test, but we do need to be asking the right questions. We need to be having conversations. We need to normalize talking about our vaginas. Right. And we need to be doing physical exams. So I think, I remember when I was first a nurse practitioner in women's health, I would often tell women like, after 60, this is your last pap smear because after 65, you've graduated and you don't have to have pelvic exams ever again. I need to wind back and go, actually, we do need to still be looking at these structures of the vagina, especially if there's an issue going on. So we need to be asking women about their vaginal health, about frequency of UTIs. We need to be looking at, oh man, I see on your chart that you've been treated for UTI 4 times in the last year. Let's talk about that. Let's talk about your, what's happening down there. Let's do an exam. Let's see if, where the structures are. Is there, we need to differentiate. Is it lichen sclerosis, which is often common with postmenopausal women, and a whole different treatment modality for that. There are some other skin conditions that can lead to these same symptoms. Yeah, absolutely. So we like to rule those out.
Yeah, for sure.
With at least an exam, sometimes infection testing. Yeah. Because vaginal infections can also lead to these types of symptoms. They don't tend to be as ongoing, right? But they can. So
yeah, for sure. So
what do you use to treat this?
Estrogen.
Yes.
I use 2 different types of estrogen. It just kind of depends on the patient's tolerability and what their specific needs are. So we have E2, which is the estradiol. That's the FDA approved formulation. That's, insurance covers. It's fairly cheap. And then there's also estriol, which is a little bit more of a weaker estrogen. That one does have to be compounded because it's not FDA approved. But I use both for different reasons. But low dose estradiol is what's in the guidelines. And that is the standard of care in the first line treatment for these symptoms of GSM.
And this is a topical estrogen.
Yeah. So it's topical estrogen in or low
on
dose.
The vagina.
Yeah. And really this is where assessment comes in, because we need to know why we're using this. Is it for UTI support? Is it for anorgasm, trouble reaching orgasm, or introital stenosis, where the vagina literally shrinks and we need to help expand and help with lubrication and things like that. So that's where a good thorough assessment comes in as to how we need to apply and use this.
And so is it applied to the outside, or is it actually inserted inside?
Yeah. So when you get your tube of estrogen, you're going to get an applicator with it. I'm going to be honest. I don't. I think you agree with me. I
Yes.
don't love the applicator.
I tell my patients to throw it away.
To throw it away. Same.
It's way too much. You end
Yeah.
up wasting most of it
Yep.
because it just then slides out.
Comes out. Yep.
It's uncomfortable.
Yeah.
In the sense that they then feel wet.
Yep.
So I'm with you.
Yeah.
Like throw that away.
I say throw it away. I mean, the only useful thing I think maybe it has is to maybe understand how much you should use, because on the applicator, it'll have a line for 1 gram and 2 grams. So if you want to know how much a gram is, how much 2 grams is.
Does it matter?
Not so much. No, but that's really, but ultimately I say throw it away, and I want you to use your finger. Get comfortable with your body.
Right.
One thing to know is that the vagina is not a sterile space. So, I mean, sure, wash your hands before, but it is fine to use your vagina. There are probably many other unclean things that go in that area that we don't worry too much about. So use your finger. It's totally fine. And again, it depends on where the support is needed. But often what I will tell patients is to start at the tip of their finger and go to about the second knuckle of it. That's about 1 gram. And then to place that interior right up against the urethra so that it penetrates the urethra. We're getting urethral support. If it's bladder help that they need, you can put it in and around the vagina, put it on the labia, put it at that 6 o'clock area of the vagina.
And the nice thing too is it's not just going to sit right in that one spot.
Right.
The vagina kind of then compresses against itself and helps kind of spread it, and it absorbs into those tissues there.
100%.
Yeah.
You can use it on the clitoris as well for arousal, and so be generous.
It's not anything that you should be afraid to use. You could likely bathe in this stuff.
Yes.
It's like
I have women use it on their face all the time.
vagina, which I wouldn't recommend. There are other ways that you can get some estrogen on your face.
Yeah.
But it's like a skin cream for the vagina.
It is. Yeah. I do want to touch on maybe some side effects really quickly that I like to address with patients, because I've had many patients when I bring up vaginal estrogen say, "Oh, I tried that. I had an allergic reaction. I can't tolerate it." So I like to kind of combat those side effects, kind of get ahead of them a little bit. So typically, depending on your symptoms, I will do a loading dose of vaginal estrogen. And that looks like, applying it anywhere from 1 to 2 weeks, nightly, 1 to 2 weeks, for 1 to 2 weeks. And then we do a maintenance dose. And not everybody tolerates that loading dose the same. So I have had some women that say, "I'm super irritated. I got a rash, or I got a yeast infection from the vaginal estrogen." And in those cases, we stop it, we treat the yeast infection, and we titrate back a little bit, maybe doing it every other night or something like that. The yeast infection is because we're bringing that lactobacillus back on board, and a vagina that's been very estrogen deprived for a long time just may need to take a slower approach at treatment. So, yeah.
What if you have a patient who's already on an estrogen patch? Does she still need that vaginal estrogen?
Yeah. 100%.
Yes.
Yes, you do. So yeah, I have women say, "Well, I'm on systemic estrogen. That should be helping." It may help a little bit. But this is where I say, we take a lot of things internally to help with our body systemically, right? So let's take the beauty industry, for instance. We ingest collagen, we ingest hyaluronic acid, we ingest vitamin C for our immune function, but we also put those things on our face to help with hydration and fine lines and wrinkles and all of that. So this is vaginal estrogen to help the structures of the vagina in the same way that we would do, take something systemically and then also apply it directly.
Right. But the systemic estrogen does not seem to target that tissue nearly well enough.
Not enough.
You can still get GSM if you are on an estrogen patch.
Absolutely.
But being on an estrogen patch and then using vaginal estrogen is not too much.
No, it's not too much at all. In fact, I will just read what the guidelines say. Clinicians should inform their patients of the absence of clinical evidence linking low-dose vaginal estrogen to the development of breast cancer. The FDA got it wrong. This is low-dose estrogen. It works very localized. Women who currently have breast cancer and are being treated with estrogen blockers should be on vaginal estrogen. They should go home with their aromatase inhibitors as well as a bottle of vaginal estrogen, because this should be preventative medicine. We should be doing something to help protect the vaginal structures when we wipe out their their estrogen, and it is completely safe.
Right.
So, yep.
It's really sad, the generation of women who have been treated for breast cancer and who have been told that they cannot use even vaginal estrogen,
Right.
because those symptoms can be so devastating and life-changing for them.
Yeah.
But it is not dangerous,
No,
is what you're telling me.
It is not dangerous.
It's not going to cause breast cancer. And
No.
if the pharmacist tells you, you probably shouldn't get this vaginal estrogen because I see you're already on an estrogen patch, which happened to a patient of mine just last month. Don't listen to them. It is.
Thank you for that information. And then use your vaginal estrogen.
Yes, please.
Yes.
Is it dangerous for their partner?
No. I mean, I love that we care about our men.
We should care about them.
We care about them, but no. So if it's not getting systemic for you, it's also not getting systemic for your partner.
Right.
I mean, don't use it as your personal lubricant. You know,
Right.
it's ideal. Save it for yourself. It's ideal to apply it after intercourse. But if you do place it and the moment arises, you don't have to turn it down. It is completely fine. In fact, they did a study just to make sure. They did a study where they doubled up on a woman's vaginal estrogen and then actually checked men's estrogen levels prior or post intercourse, and they didn't raise at all. So it's totally fine.
I would agree, though I wouldn't use it as the lubricant.
Right. But again, sometimes we don't plan these things, and it's fine.
We like the spontaneous.
Yes.
Well, what are some things that women might be able to do at home if they are curious and think that maybe they have GSM?
I mean, at-home treatments really aren't going to be as effective as estrogen. So, I mean, I'm a fan of personal lubricants. I'm a fan of oil-based lubricants that you can use, to help during intercourse, but then also for your own personal care of that area as well. My preference is organic coconut oil. That's probably my favorite. And that will help. I mean, it'll help moisturize, and it will help initially, but it's not going to help with any of the bladder symptoms. It's not going to help long term. It's just certainly not going to be as effective as
It's not going
estrogen.
to change the structure of the tissue.
Or the flora, or,
the environment in there.
Right.
Is there an age limit to who can use vaginal estrogen?
No.
Definitely not.
80-year-olds can use vaginal estrogen. Yes. Yeah, absolutely. In fact, there was an interesting study in 2024 done looking at just medical costs related to urosepsis in women on Medicare. And it was said that if the government mailed a tube of vaginal estrogen to every woman on Medicare, so that's every woman over 65, we could save the government in medical costs at upwards of $20 billion.
That's insane.
$20 billion in urosepsis and other urogenital causes for hospitalization, and so it's totally safe.
It sounds like a medication that most women should be on.
Absolutely.
Not only those women who are postmenopausal and not having menstrual cycles any longer.
Right.
I do feel like starting vaginal estrogen can improve.
It can be
the
preventative
tissue down there,
yeah.
But I feel like it works better if you start before any major changes have occurred.
Absolutely.
So women who are even perimenopausal.
Yeah. I mean, if it's an issue for you, I mean, that's why it should be a part of every yearly examination or yearly physical. We should be talking about vaginal health, and a lot of women don't realize that I mean, the definition of menopause has really been misconstrued, I think, historically. And women tend to think that because I'm still having periods means I'm not having hormone fluctuations and I'm not menopausal yet. So these symptoms are just me. Like all of a sudden I just am drier down there. I'm agitated. I'm getting more UTIs. And they don't realize that, in my opinion, menopause is just the significant decline of these hormones in comparison to our reproductive years, and that can happen at any time. So there's nothing magical about periods. You can certainly have these same symptoms as a 40-year-old, mid-40s, early, even 30s. I've treated some women as early as late 30s for some of these symptoms. So it can be beneficial.
About you, but in my opinion, I would rather I would rather start myself
prevent
for me
yes
before I get to that point. And I think that's something that can be discussed with women and let them decide if they agree with that for themselves.
Right.
Yeah.
Absolutely. So,
well, Taelor, I feel like that was another great conversation.
Yeah.
Do you have anything more you'd like to add?
No, I mean, just, get comfortable. Get comfortable with your body, knowing the changes of your body.
Right.
Get comfortable. Find a provider that you're comfortable with having these conversations with, and the more education that you can have, the more you can promote self-care and find a provider that can help you navigate the changes that your body goes through. So just
don't be afraid to advocate for yourself.
Absolutely. Yeah.
Well,
vaginal estrogen for everyone.
Well, thank you, Taelor. It was so nice to have this conversation with you today. We just want to mention that Taelor and I are both practitioners, but we are not your practitioner. There's no doctor-patient relationship that has been established.
If you're interested in seeing any one of us as your provider, you can find us at Valley Hormone and Wellness. We're located in Pleasant Grove, Utah. We also do telehealth appointments. We would love to help you where we can.
And we'll see you later.
Till next time. Thank you.